Well, hello everybody. My name is Lisa Majeski and I'm the president of Gold Star Medical Business Services. Gold Star Medical is a full-service medical billing company, and we also provide staff training, compliance auditing services, and clinic productivity services for doctors and chiropractic offices throughout the United States. Today's presentation is going to be on injection billing practices for multidisciplinary practices. And this is specific to practices that were in the beginning a chiropractic practice, and now the chiropractic practice has gone on to form a multidisciplinary clinic or a multi-specialty clinic in which the chiropractor has now hired an MD and a nurse practitioner to be able to expand the services beyond the scope of chiropractic. And one of the most common procedures that is introduced into a multi-specialty practice for chiropractic offices is the injection billing and the injection procedures. And so today's presentation is going to be simply on injection billing and coding practices for the multidisciplinary specialties. For those of you who may want more information about this after the presentation is over, you can reach me by my email at goldstarmedical@msn.com, and my phone number is posted on this slide as well. You can also check us out on our website on www.goldstarmedical.net. So let's go ahead and get started. Injections is probably one of the most, from a medical coding standpoint, complicated coding scenarios, other than, of course, surgical procedures and so on and so forth. But there are many, many different types of injections. And so one of the things that you need to understand when you begin to deal with injections in your practice is the type of injection that you're going to be dealing with in the practice that you have. So these are the injections that are listed here on your screen are all of the different types of injections that could be administered to a patient. We have therapeutic injections, we have the long-lasting anesthetic injections, aspirations, infusions, we have hydration, you have allergens, so injections for resistance to allergens, vaccinations, and biopsies. And so in this particular presentation, we're going to be dealing with the first three types of injections, which are the most common types of injections utilized in a multi-specialty practice that is a doctor of chiropractic, nurse practitioner, or doctor of chiropractic, and MD. They're your therapeutic injections, your anesthetic injections, and your aspirations. So let's go ahead and get started. So the first thing you need to know when it comes to injections is, what is the purpose of the injection? So is the injection going to be for delivery of a medication? Is it going to be a nerve block? Is it going to be an injection into a trigger point to eliminate pain? Is it an injection for immunity buildings, such as vaccinations or allergy injections? Is it hydration, like an IV fluid bag? Or is it for removal of fluid in tissue or joint, which is called aspiration? And so you need to know what the purpose of the injection is before you can properly code for the appropriate type of injection. The other thing you need to know when you're doing injection billing is the anatomical site of the injection. So one of the things a doctor of chiropractic and a nurse practitioner need to make sure of when they are documenting for injections is that they're very, very specific on the site and location of the injection. And remember that when you're doing injections into limbs such as knees, shoulders, and so on and so forth, laterality will come into place. So you'll have to make sure that not only do you list the anatomical site, but the specific location of that site. Is it the right shoulder, the left knee, or so on and so forth? The other thing you need to know is the method of delivery. So is the delivery of the injection going in intramuscular, subdermal, oral or nasal, paravertebral, or vascular using a PICC line. So there are a number of different methods of delivery for these different types of injections. The other thing you need to know when you are coding for injections is the drug or the injectable material that you're using. So the name of the medication and the dosage. And you have to be within your documentation very, very specific about the name of the medication and the dosage. And as we go through the rest of this presentation this morning, you'll get to understand why the dosage is so important. The other thing you need to know with respect to injections is whether for certain injections, guidance is used to deliver the injection, and guidance is going to be the most common are going to be ultrasound guidance or fluoroscopy, X-ray guidance. And what we mean by that is as the injection is being administered, you are viewing the internal component of the body either through ultrasound or through fluoroscopy so that you're placing the needle in the correct spot. And so guidance sometimes is used to deliver these types of injections. So let's talk about the most common types of injections that when a chiropractor goes to a multidisciplinary practice, they hire a nurse practitioner or an MD, or they have a medical director with a nurse practitioner working under the auspices of the medical director. The most common injections that are introduced into this chiropractic practice are going to be number one, trigger point injections. This is probably the most common of the injections. And the two codes for the trigger point injections are 20552 and 20553. And you'll notice the difference is in the number of muscle groups that are being injected. So a 20552 is an injection for single or multiple trigger points. This is 1 to 2 muscle groups, or 20553, which is the injection single or multiple trigger points into 3 or more muscle groups. So let's talk about what a trigger point injection actually is and what happens. So in the TPI procedure, a healthcare professional will insert a small needle into the patient's trigger point. The injection contains usually a local anesthetic or saline and may include a corticosteroid. With the injection, the trigger point is made inactive and the pain is alleviated. Often a brief course of treatment will result in sustained relief. Injections are given in a doctor's office and usually take just a few minutes. Several sites may be injected in one visit. So one of the things that chiropractors love about these trigger point injections is that they can send the patient to the nurse practitioner for a trigger point injection, alleviate the pain in those trigger points, and then it allows the chiropractor to deliver a much more robust adjustment, spinal manipulation to that patient, because they're not experiencing that type of myofascial pain, which can restrict their ability to do a really vigorous chiropractic adjustment. And so it's almost like being able to manipulate a patient under anesthesia, except you don't have the dangers of a general anesthesia. So you're essentially deadening those areas in order to be able to deliver a better and more effective spinal manipulation. So trigger point injections are very, very commonly used in the multispecialty practice. Now, what I'm going to talk about today mainly is going to deal with Medicare coverage of these types of injections. But please understand that when we're talking about Medicare coverage, most commercial payers are going to follow the Medicare guidelines. And so if you know how to follow the Medicare guidelines for these types of injections, you'll also know typically how to follow the guidelines under the commercial payers. There may be a few variances, but for the most part, if you're doing it right and you're doing it the Medicare way, you're typically covered under the commercial payer guidelines as well. So what does Medicare say about trigger point injections? They have Medicare has something called a local coverage determination for trigger point injections, and the Medicare LCD for trigger point states that after myofascial pain syndrome is established, trigger point injections may be indicated when non-invasive medical management is unsuccessful. For example, the patient has taken analgesics, they've done passive PT such as e-stim or traction, ultrasound, range of motion, and active exercises. So these have not worked. And so the TPI injection is considered a bridging therapy to relieve pain, while other treatments are also initiated, such as medication or physical therapy, or in the case of chiropractic, it would be the chiropractic manipulation. Or it can be as a single therapeutic maneuver. The logic behind such therapeutic decision-making should be obvious in the medical record and available upon contractor's request. And essentially what that means is that you must have supporting documentation to substantiate the need for these trigger point injections. Additionally, trigger point injection is indicated when joint movement is mechanically blocked, as is the case of the coccygeus muscle. So again, I'm taking this directly from the Medicare policy LCD. This was the Novitas Solutions LCD, so this is for Mississippi, Texas, Oklahoma. There are a number of other states also up in the Northeast that Novitas is the LCD. New Mexico also uses Novitas as their Medicare fiscal intermediary, and every fiscal intermediary or Medicare administrative contractor is going to have an LCD for trigger point injections that will give you similar wordage and verbiage of what the indications would be to establish medical necessity for trigger point injections. They also will provide you with approved ICD-10 codes. And so you'll notice I simply copied and pasted from the Novitas LCD the ICD-10 codes that are approved for these trigger point injections. So be aware that if you set as a primary diagnosis any other code other than these diagnosis codes, your claim to Medicare would be denied for the injections. So for chiropractors, you know that for the spinal manipulation, the primary diagnosis code is the M99.01 through 05 codes. And so when a trigger point injection is delivered, you're actually going to have to change the primary diagnosis code to one of the codes that are listed here in your LCD. The most common one that I see are either the M54.2 cervicalgia, low back pain, pain in thoracic spine, or the M79.1, which is the myalgia code. But again, depending on where the trigger points are being administered, let's say the trigger point is going to be in the upper arm, then you're going to, and it's the left upper arm, you may use the M60.822, other myositis, left upper arm. And so be aware that there are a number of approved diagnosis codes for trigger point injections, but you have to make sure that you're pointing the correct diagnosis code to that particular service of the 20552 or 20553. Now, some coding tips for the trigger point injections. Number one, TPI is coded based on the number of muscle groups injected, not the number of injections. And I see this as a common error. So what I've seen in the past is doctors or the nurse practitioner will do 8 different injections, and then they will code at 20553 because they did 8 injections. But the injections were all in the cervical and thoracic area, and it only represented 2 muscle groups. And so the correct code would actually be a 20552. So be aware of that. Another thing to be aware of is if you do an exam or an evaluation and management service on the same day as an injection, you have to be very clear in your documentation that a separate evaluation and management code or service was performed, and make sure that you place the 25 modifier on the E&M code so that the service will not be bundled into the E&M code or vice versa. Also be aware that it is not appropriate to code an evaluation and management service every time the patient comes in for a trigger point injection. I've also seen that as an error, not as common. I don't know if there are certain groups that recommend the doctors do that, but when we've gotten a hold of the practices that have been billing for the E&M services at every visit that a trigger point injection is performed, we've told them to stop doing that because typically an E&M service is not being performed. It's the same. You need to think about it the same way as a chiropractic manipulation. So when you have a patient on a treatment plan for manipulations, you don't code an exam with every manipulation. You code the exam at the beginning of the treatment plan, and then if the treatment plan is going to be modified. So the only time an E&M code would be warranted under a series of trigger point injection treatments would be if the patient is having a bad reaction and you have to do an exam to determine why, or if you're going to modify the treatment plan, then you would do an exam to justify the modification for that treatment plan. So be aware of that. And also for TPI injections, typically the injectable medication that is used within the injection itself is not separately reimbursable. The most common solution for a trigger point injection is lidocaine, because lidocaine deadens the trigger point. And so essentially you'll inject a 2% lidocaine into the trigger point to deaden the area. That 2% lidocaine is considered sort of like a local anesthetic, and as such it is not considered to be separately reimbursable. Now there are times where the medications can be separately billed for, but not in the instance of trigger point injections. Okay, although it is important for the provider to document the solution that was used and the dosage and the percentage of solution that was used for that particular injection. The next most common procedure that is performed in a DC MD nurse practitioner practice are the arthrocentesis codes. Arthrocentesis is essentially a procedure in which you're going to be removing fluid, buildup of fluid around a joint, and then injecting medication into that joint to prevent degeneration of arthritis or whatever. And so the most common codes are the 20600, 20605, and 20610. And you'll notice that the difference in these codes has to do with the size of the joint that is being aspirated. So the 20600 code is the arthrocentesis of a small joint, and they give the example of fingers or toes, and this is without ultrasound guidance. 20605 is for the intermediate sized joints, for example the TMJ, the wrist, the elbow or ankle, without ultrasound guidance. And then you have the arthrocentesis of the large joint, which is the shoulder, hip, knee, and this is also without ultrasound guidance. The knee joint injections are quickly becoming, or the arthrocentesis procedures on the knees are quickly becoming one of the most popular of the treatment regimens in a multi-specialty practice that has a DC and a nurse practitioner, or a DC and an MD. You also have the arthrocentesis codes with the ultrasound guidance. So if the nurse practitioner or the MD is using ultrasound to guide the needle, then they would use these codes instead, the 20604, 06, and 11 codes. And again, this is going to be based on the size of the joint. So if it's a small joint, it's with ultrasound guidance 20604, and so on and so forth. The large joint injection with ultrasound guidance is going to be 20611. And so you have essentially 6 codes that could be used for the arthrocentesis procedure. And you're going to need, what are you going to need to know? You're going to need to know, again, the very specific location of the procedure, whether it is considered a small, intermediate, or large joint, and you're going to need to know whether guidance was used, whether ultrasound guidance or fluoroscopy. So essentially, a joint aspiration is a procedure whereby a sterile needle and syringe are used to drain synovial fluid from a patient's joint. Joint aspiration is typically performed by a doctor or ancillary healthcare provider, such as a nurse practitioner, as an office procedure or at the bedside of hospitalized patients. Joint aspiration is also sometimes called joint drainage and is medically referred to as arthrocentesis. So a patient, just to give you a little bit of background of how a patient would prepare for this procedure, they don't need to do anything special. It's not like they need to, go 24 hours without eating anything. They're not going to be under any kind of a general anesthetic. A local anesthetic is typically administered to the area, either applied to the patient's skin or just beneath the patient's skin. Usually there may be a slight amount of pain as the needle is inserted into the patient's joint space, and then withdrawal of the fluid back into the syringe typically does not cause pain. The injection of the medication then into the joint typically also does not cause pain. There might be a slight pain sometimes as the needle is withdrawn from the joint. Any pain is reduced by topical or local anesthetics that block pain sensation. And so this is typically not a painful procedure. It typically does not take a long time to do, maybe 10 minutes at the most. And most of the time what the patients will report is that they feel immediate relief once the additional fluid is drained from the joint space and as the medication is administered into that joint space. Joint aspiration can be used both for diagnosis and medical treatment of arthritis of a joint. So typically, the primary diagnosis for arthrocentesis is going to be some type of osteoarthritis diagnosis code. It is also a helpful treatment in relieving joint swelling and pain. So what happens is that when the removal of the synovial fluid from the joint that's inflamed takes place, it also removes the white blood cells within that are the sources of the enzymes that can be destructive to the joint. And so it actually helps the joint from having further deterioration. So this treatment can more rapidly restore the health of the joint. Now, I'm telling you all of this because many of you who are going to be listening to this may not be doctors. You might be chiropractic assistants who are not familiar with what these procedures are. And if a patient asks you, well, what is this? I mean, the doctor is telling me I need this service, but really, what is it? You can give them a summary of what the arthrocentesis and the trigger point procedures actually are. Medications that are used in joint injections are commonly, it's going to be some type of an anti-inflammatory medication such as cortisone. This can rapidly relieve joint inflammation and further reduce symptoms. But one of the most common of the medications that are used in joint injections, especially in the knee, are the hyaluronic acid derivatives like Hyalgan, Euflexa, and so on and so forth. These are specifically approved for pain relief of the knee in degenerative arthritis conditions. It can rapidly relieve joint inflammation and further reduce symptoms. So typically what will happen is that aspiration will take place first. The fluid is removed, then followed by the injection, and this can be done in without having to change out the needle. So typically what happens is the needle is placed with a syringe, the fluid is taken out, then the syringe is replaced with another syringe that has the medication in it, and then it is simply injected. So it's not like the patient is going to have two separate injections. And so it's it makes it much safer that way and less stressful for the patient. So getting down to the coding, now in the aspiration codes and in the arthrocentesis codes, you will be billing for the injectable medication. And so these codes are actually found in your HCPCS code book. These are not in the CPT code book. So there are two coding books. You have a CPT code book and a HCPCS code book. And the HCPCS code book will contain the full list of all drugs and injectable materials that are used in these types of procedures. And so not only, and this is actually coming directly from the Medicare LCD of Novitas, which is again for Mississippi, Texas, Oklahoma, Arkansas, New Mexico. There may be a couple of other states that I didn't include here, but you can check with your LCD. But this also gives you the dosing frequency, and this is super important because if you exceed the dosing frequency per the LCD, Medicare may not pay for it, and your commercial payers may not pay for it. And you need to understand that these dosing frequencies are listed on the packaging inserts of these particular drugs. So it's going to give the recommended dosages on the drugs themselves. And so if recommended dosages are exceeded, then it may not be paid. So one of the things that you need to be aware of is, let's say you have a patient and you're doing Hyalgan injections on the right knee, and you've given the patient the 5 weekly injections of 20 milligrams once a week. And now the patient comes back to you and says, boy, I'm feeling 90% better, but I think one more dose would be great. If you could do one more dose, would you be able to do that for me to get me to 100%? You would need to have the patient sign an ABN form if it's Medicare, or a notice of non-coverage if it's not Medicare, whether it's your own internal ABN form or if it's a Medicare replacement policy and they have their own ABN, or a commercial payer that has their own version of an ABN. You would make sure that you get an ABN for that excess of the injection, because if you bill that 6th injection to the carrier, they will not pay for it because the dosing frequency is 3 to 5. And so you have to be aware of that. Okay, so and it goes by the drug itself. So if it's Hyalgan, it's 3 to 5 weekly injections. If you're doing Monovisc, it's a single injection. And so, and of course, the difference is going to be that Monovisc is a much higher dollar injectable material, so it costs more, so the procedure is going to be more than if you're doing a Hyalgan injection once a week for 5 weeks. Okay, so be aware of the dosing frequencies of these different types of drugs that you may be using for the arthrocentesis procedures, and here are the rest of them. Okay, and again, it also gives you the recommended dosages per knee. So, for example, how many milligrams should be dosed within that particular injection. So be aware that these are very, very strongly adhered to in the carrier's determination of whether these drugs are going to, and these injections will get paid or not. If you are billing for a series of injections, and a series is defined as a set of injections for each joint and each treatment, you will have to use a modifier for the subsequent injections. So if you're coding a 20610, which is a large joint injection or a knee injection without ultrasound guidance, and you're going to do the first injection of Hyalgan and then 3 more injections 1 week apart, the subsequent injections will need to be coded with the EJ modifier. And the EJ modifier will be coded on the drug code, not on the injection itself, but on the drug code itself. So the modifier is not to be used with the first injection of each series. The other thing you need to know about, and we'll talk about this a little bit more right at the end, is that if a portion of the drug is discarded, the medical record should document that the amount administered and the amount wasted. It's called drug wastage. And you can actually bill for that. You can bill for drug wastage with an appropriate modifier, and we'll go over that later on. These are your diagnosis codes that are approved under the Medicare LCD for coverage of these drugs, okay? And so these are the different drugs that, you know, the J7320, 21, 22, 23, this is your Hyalgan, your Euflexa, and so on and so forth. And so you'll notice that all of these, number one, are knee diagnosis codes. So large joint injections are only going to be considered for osteoarthritis of the knee for to be able to bill for and get paid for the Hyalgan injections. They do not cover the shoulders, for example, under Medicare. It is only going to be for the knee. So be aware of that. A repeat series of Hyalgan injections for patients who have responded to the first series is considered to be reasonable and necessary under the following circumstances. So let's say you have done a series of injections, knee injections on a patient. You've done 3 to 5 injections on the right knee. They feel pretty good. They've had significant improvement in pain and functional capacity. They've had significant reduction in the doses of NSAIDs that they've had to take, and there's been a reduction in the number of intra-articular steroid injections to the knees during the 6-month period following the injection, and at least 6 months have elapsed since the prior series of injections. So the other thing that you have to be aware of is if a patient comes to you, let's say you've done a series of knee injections, and now they come to you 4 months later and they say, you know, my knees are starting to bother me again. Do you think we could do a few more of the Hyalgan treatments? You would need to let the patient know that because 6 months has not elapsed since their last series of treatments, that they would have to pay for that out of their pocket, and you would have them sign an ABN form to and make sure when you code it that an ABN is on file with the GA modifier. Okay, so be aware of that the guidelines is that if you're going to do a repeat series, you can do that for the patient, but they may not, and you have essentially what's called a global period of 6 months in which any other services that are done within that period are not going to be paid. So it has to be at least 6 months that's elapsed since the prior series of injections. And one of the things that I have found is that the commercial payers pretty much adopt these guidelines as well. So I would make sure that if you're a biller and you're listening to this, make sure your providers know what these parameters are so that if a patient does come back for a repeat series of treatments, that you're coding it correctly. Ultrasound guidance is not to be coded separately for the 20604, 20606, or 20611 because the guidance, ultrasonic guidance is actually its own CPT code, 76942, but you don't code it separately because guidance is already included in these 3 codes. So be aware of that. Now, some providers will use fluoroscopic guidance for needle placement, for example, biopsy, aspiration, injection, and fluoroscopy is more of a radiology code, and it can be billed separately as an add-on code to the 20610. So you would bill the 20610 large joint injection arthrocentesis without guidance, okay? without ultrasonic guidance, but you would add on the fluoroscopic guidance code in that case. So you need to find out from your providers if they're using ultrasound or fluoroscopy as guidance tools for these types of injections. And if they are using ultrasound, then it's a different code. If they're using fluoroscopy, then you're going to use the 20610 code with the 77003 code. Now, as is with the trigger point injections, you can bill an evaluation and management or an exam code in conjunction with the initial injection. You would use a 25 modifier on the E&M code, but they are not to be billed for subsequent injections in a series unless there are complications of care that need to be documented. And be aware that the medication that is being delivered in these injections are separately reimbursable. So some more coding tips on these arthrocentesis procedures. If an aspiration and an injection procedure are performed at the same session, bill only one unit for CPT code 20610. So let's say the doctor wanted to do the injections on both knees. You would only bill one code, 20610, and then use the modifier 50, which would be bilateral procedure. So you would not code 20610 RT for the right knee and then another unit of 20610 LT for the left knee. Okay, and that goes for any of the, if you do arthrocentesis on shoulders, elbows, fingers, you can only do one of those codes per session. Okay, so it's going to be right side, left side, or bilateral. What we find is that most providers will not do bilateral injections because of the fact that the 20610 with the bilateral will not pay for the full amount of the 20610 if it's done on different days. So typically what will happen is the patient will come in one day for an injection on the right knee, or they'll do a series of once a week for 5 weeks on the right knee and then once a week for 5 weeks on the left knee, so that they can receive the full reimbursement instead of being paid like 1.5 times if you do it bilaterally on the same day. So it definitely is to the benefit of the provider as far as the reimbursements go if they do only one knee or one appendage at a time. The appropriate site modifier must be appended to the drug code also to indicate if the service was performed unilaterally or bilaterally. The drug must be reported on a separate claim line for each knee or shoulder treated using the appropriate site modifier, RT or LT. Claims without a modifier will be returned to the provider unprocessed. And then also remember the EJ modifier on drug codes to indicate subsequent injections of a series. Don't use this modifier for the first injection of each series, and a series is defined as the set of injections for each joint and each treatment. The injection of the left knee or shoulder is a separate series from the injection of the right knee or shoulder. So just to be aware of that, using that EJ modifier, and the modifier is put on the drug codes. So what that means is it's put on the J codes, not on the procedure code. The other type of injection that you might encounter in a multi-specialty office are going to be your intramuscular injections. The code for an intramuscular injection is 96372. Now don't confuse an intramuscular injection with a vaccination. There's a big difference between a vaccination and an injection. A vaccination is introducing a toxoid into the body to build up immunity to disease, okay? And there's completely separate codes for vaccinations. And it's very, very specific. And it's very, very specific as to whether the vaccination is performed on Medicare patients. There are Medicare codes for vaccinations and non-Medicare codes. So if you're listening to this and you are a multi-specialty office that has broadened your scope into being more like an urgent care clinic where you are going to be offering flu shots and vaccinations, please get with me and we can do separate training on that. But for the majority of the DC MD or DC nurse practitioner offices, you're not going to be dealing with vaccinations. You will be dealing mostly with the intramuscular injections. And what an intramuscular injection is an injection that will deliver a small volume of medication in a single shot. So the substance is given directly by either subcutaneous, intramuscular, or intra-arterial routes, as opposed to an IV push that requires a commitment of time. And most of the time in the DC multispecialty offices, you're not going to be dealing with intra-arterial injections. It's either going to be subcutaneous or intramuscular. The most common medications that I have seen used in the DC-MD practices for intramuscular injections are your Toradol, Ketorolac, and Depomedrol. Now, there may be others out there that you use, and if you need to determine what the appropriate drug code is to bill it in conjunction with the injection, you can see me, or you can contact me at my contact information, or you can look it up in your HCPCS manual, or if you have a Find a Code subscription, you can look them up there as well by typing in the name of the drug, and it will give you the appropriate code. Now, be aware that, for example, Depomedrol has about 6 or 7 different codes, and it has to do with the type of Depomedrol it is and the dosage. So you have to be very, very particular when you're looking up a drug code that you are looking up the exact drug that you are injecting into the patient. And that is not just the name of the drug, but the dosage of that drug as well. CPT codes 96372 should be reported for each intramuscular injection performed. So if you perform 2 or 3 injections, it would be appropriate to separately report this code for each injection. So let's say, you inject Toradol into the hip and then into the, middle part of the back or something like that, then you could, and maybe you're using different drugs even. You would be able to code for separate injections. In that case, you would code each subsequent injection with a modifier 59 distinct procedural service. Okay. And also note that for professional reporting 96732, 96372, that is a typo in there. It's not 96732. This requires direct physician supervision. It's reported per injection, even if more than one substance or drug is in the single injection. So, and then finally, the last thing I wanted to talk to you about is drug wastage. So we talked about it a little bit earlier in the presentation. You can report drug waste for those drugs the billing entity paid for and provides. Now, you as the provider are the billing entity. And so if you bought the drugs and you are providing them for the patient, then you can bill for the wastage. You would not bill for the wastage if the patient brings the drug with them, they purchased it from a pharmacy and they brought it with them, or would you report waste for drugs that are supplied by a facility, so they bring it from the hospital. Okay, report the drug using the appropriate J code and the correct number of units in box 24D of the CMS 1500 form. What do we mean by number of units? Let's go back to the intramuscular injection, just as an example. So let's say the doctor in the documentation stated that they administered 30 milligrams of Ketorolac intramuscularly to that patient. One vaccination of 15 milligram of a 30 milligram total. And so what that means is that would be, since the Toradol is coded as a 15 milligram dose and 30 milligrams were administered, then you would code the drug times 2. So it would be J1885 times 2 units. Okay, so make sure you have not only the code, but the correct number of units. So if the appropriate J code indicates 15 milligrams, but the documentation shows 45 milligrams, that's 3 units of that J code. And so be aware of that when you're coding that on the CMS 1500 form. If there was any wastage, it should be noted in the documentation, the exact dosage that was injected and the exact amount and reason for any waste, okay? The wasted units would be entered as a second line item, and then a modifier would be placed on that drug code of JW. That is drug amount, that stands for drug amount discarded, not administered to any patient. This will be used to identify an unused drug from the single-use vials or single-use packages that are appropriately discarded. Make sure you check with your individual payer whether modifier JW is required. It is required on Medicare. It may or may not be required on your commercial payers. Okay, so that concludes our presentation of injection coding for multi-specialty practices. This will give you at least a taste of the injection coding procedures. And I want to thank you very much for your attendance today. And again, if you do have any questions whatsoever about injection coding or billing, please feel free to reach me at the numbers and the email addresses that are listed here on your screen. Thank you again for your attendance, and we'll talk to you again soon.